Hello guys, welcome back to Clinically Clear. So now I'll be covering some aspects of tuberculosis which I have not covered in my NTEP video. So if they ask, tell tuberculosis epidemiology and then explain the control using NTEP, watch this video as well because it is very important. So let's start with the introduction. Basically, what is the problem statement? In India, TB is a very big public health problem. Basically, the highest burden of TB in any country in the world is in India. Incidence is 167 per lakh of population. New cases per year is the incidence of TB. So it is a very big public health problem in India. The epidemiological triad, which is agent factors, host factors, and environmental factors. The environmental factors are poor poverty, social economic status, low social economic status, overcrowding, undernutrition. All these are environmental factors. Host factors are, the peak age of tuberculosis is between 15 to 45 years old. It is more common in males. Malnourished individuals are higher risk of contracting tuberculosis. That is host factor. Agent factor, what is the causative organism? The most common causative organism is Mycobacterium tuberculosis. It can also be caused by Mycobacterium bovis, Mycobacterium africanum, etc. The source of infection for Mycobacterium tuberculosis are humans who have positive sputum sample. So humans with positive sputum sample are the source of infection. Whereas for Mycobacterium bovis, the infected milk from a cow is the source of infection for Mycobacterium bovis. You also have atypical mycobacterium, photochromogens, Mycobacterium kansasi, scotochromogens, Mycobacterium scrofulaceum, non-chromogens, Mycobacterium intercellulare, rapid growers, Mycobacterium fortuitum. All these are atypical mycobacterium. So agent factors, the causative organisms, the source of infection in the atypical mycobacteria. Host factors, 15 to 45 years old, males, malnourished. Environmental factors, overcrowding, poverty, poor, low socioeconomic status, etc. Then coming to the mode of transmission, obviously respiratory route, infected droplet nuclei, incubation period is quite long, 6 months. Diagnosis. Now, screening test of choice is sputum microscopy. Basically, you'll ask the patient who has come to you with chronic cough, etc., for a spot sputum sample right there, spot sputum sample that day itself, and the next day an early morning sputum sample and a hungry stomach. You should not eat anything, early morning sputum sample. The sputum sample should be more than 5 ml, it should be thick, it should be purulent or it should be mucopurulent, and obviously it should not be contaminated with food particles and all. And even if one of these sputum samples are positive, spot sputum sample or the early morning sputum sample, we consider it as a positive report. The stain used for this sputum microscopy is Zn stain can be used. This is in the olden days. LED microscopy is also much better, but this also is not that commonly used. Nowadays, we use fluorescent microscopy using auramine stain. So auramine stain is used for detecting acid fast bacilli in sputum sample. So sputum microscopy is still the screening test of choice. Then you have molecular methods like PCR. You have CBNAT, cartridge-based nucleic acid amplification test, also known as GeneXpert, also known as TrueNAT in India. This is a modification of CBNAT is TrueNAT in India. And investigation of choice for confirmation and diagnosis of TB is CBNAT. So it is a universal test. Just because you get a positive sputum report does not mean, okay, his pakka TB, diagnosed to be TB, let's start on anti-tubercular therapy. No. This is a universal test for TB patients. Every single TB patient, you have to do CBNAT. You have to confirm and diagnose by CBNAT. Only then you will say it is pakka TB and then you will start anti-tubercular therapy. Why do we do this? One more reason why we do this, it tells us the status of rifampicin sensitivity. CBNAT tells us whether the strain is sensitive or resistant to rifampicin. Because if it is sensitive to rifampicin, then you can go for a different regimen. If it is resistant, you can go for another regimen. So that is one big advantage. And it gives us a report within 90 minutes. Within 90 minutes, the cycle is complete. You know whether you are TB positive or TB negative. So you can detect Mycobacterium tuberculosis right there. Whereas sputum microscopy can take up to 48 hours, depending on how much laboratory workload is there, etc., etc. It can vary. You have an even more advanced molecular method known as line probe assay, and this tells the resistance to first line anti-tubercular drugs like isoniazid, not just rifampicin, and also tells us the sensitivity to second-line anti-tubercular drugs like fluoroquinolones and amikacin. So this we do to to identify whether it is multi-drug resistance, pre-extensive drug resistance. I have mentioned the diagnostic algorithm in the NTP video. Next method of diagnosis is culture. See, the solid culture medium is of course LJ medium, Lowenstein-Jensen medium. This liquid culture medium is Middlebrook medium. You also have certain automated culture colony identification methods like BACTEC and MGIT. So BACTEC will identify the carbon dioxide released from the live bacilli. MGIT will detect the oxygen consumption by the live bacilli. So if there are any colonies with live bacilli, these systems, BACTEC system by detecting carbon dioxide release, MGIT by detecting oxygen consumption, can help us identify the culture colonies. Then you have tuberculin sensitivity skin sensitivity test or Montu test. Intradermal injection of tubercular antigen is given, and then after a certain duration we'll look for a wheel and flare response and we'll look for induration. If it is present, that indicates that there is a type 4 hypersensitivity reaction to the tubercular antigen. This indicates that the person has been previously exposed to TB, past exposure or past TB infection, or it could be a current infection as well. It is not a diagnostic test. It just tells us whether the person has been exposed to TB in the past. If a person has received BCG vaccine, tuberculin skin sensitivity test, Monto test will come positive because he has been exposed to tubercular antigen, right? There is immunity against tuberculosis in the person's body. You also have non-specific findings like chest X-ray, which can be done on a routine basis as a screening method as well. So these are all the diagnostic techniques. Remember that the investigation of choice for confirmation diagnosis is CBNAT. It is a universal test. Screening test investigation of choice. CBNAT is also the screening test in HIV patients. HIV patients will directly go for CBNAT. We won't do sputum microscopy. Otherwise, the screening test of choice is sputum microscopy. That is it for tuberculosis. Thank you for watching.